Hello and welcome to this special EULAR review podcast brought to you by the IMED Forum. My name is Xenofon Baraliakos and I'm head of rheumatology at the Rheumazentrum Ruhrgebiet Herne in Germany and professor for internal medicine and rheumatology at the Ruhr University Bochum in Germany. I'm joined today by Laura Kotz, professor and senior clinical research fellow at the Nuffield Department of Orthopedics, Rheumatology and Musculoskeletal Sciences at the University of Oxford, and Sofia Ramiro, consultant rheumatologist and senior researcher at the Leiden University Medical Center in Zuiderland Medical Center in the Netherlands, and visiting professor at the Nova Medical School in Lisbon. Welcome, Laura. Welcome, Sofia.
Thank you very much.
Thank you.
Nice to see you again. So in this podcast, Laura, Sofia, and myself will reflect on some of the presentations from this year's EULAR Congress that we believe are particularly relevant to the clinicians and researchers who are listening here. The Congress included updates across rheumatoid arthritis, psoriatic arthritis, and axial spondyloarthritis, with new insights into the disease assessments, treatment approaches, and patients' outcomes. We have also captured many of these developments in our EULAR highlight brochures. So without further ado, let's get started. And I will start myself with some selected abstracts for rheumatoid arthritis. So one of those abstracts has been an oral presentation from Alpach and colleagues. The title is CD19 CAR T-cell therapy in AxSpA positive treatment refractory active rheumatoid arthritis. It's the so-called COMPARE trial. It's a phase 1 trial, prospective and interventional, obviously. I would like to remind you of the background. COMPARE has evaluated the mirvetuximab autoleucel and autologous fully human CD19-directed CAR T-cell therapy in rheumatoid arthritis patients who have been clinically active, AxSpA positive, and treatment refractory, as usually in those studies. There have been 6 patients receiving the CAR T-cell therapy after fludarabine and cyclophosphamide lymphodepletion. And all of those patients had high disease activity at baseline, means median DAS28 CRP of 5.5. They've also been treated priorly with other biologics. In the median number of prior biologic and target synthetic tumors has been 6.5. And 4 of those patients had prior treatment with rituximab. The key takeaways from the study is that the MIF-cell treatment was generally well tolerated. CRS, we know that we have to pay attention to, that was mild to moderate, and there were no ICANS or unexpected toxicities that occurred. The CAR T-cell expansion was rapid with profound B-cell depletion in all patients. We know that this is important, especially in rheumatoid arthritis, because that expansion is not so well established in terms of it being that fast, and that's why we have to pay attention at. The antibody reductions were marked, so AxSpA positivity and seroconversion to normal values was seen in 4 out of 6 patients, and the rheumatoid factor seroconversion to normal values was seen in 5 out of 6. The median DAS28 CRP decreased by 41% from screening to the latest follow-up. Half of the patients achieved remission of DAS28, and all but 1 patient remained off immunosuppressive therapy during the follow-up. This means these findings do support the early evidence for an immunological reset approach in highly refractory rheumatoid arthritis, a disease that has not yet been that much evaluated for CAR T-cell therapy, and it's certainly one of the main focuses of the next years to come. Another study that was, I believe, interesting was also an oral presentation given by Gerd Burmester, who evaluated the long-term safety of upadacitinib in clinical trials and in clinical practice settings for all safety issues, including infections, malignancy, cardiovascular events, and thromboembolism in the indications where the drug is approved. This means rheumatoid arthritis, psoriatic arthritis, or axial spondyloarthritis. And we know that we do need this data because we are using JAK inhibitors. Overall, in these diseases, still we are lacking some long-term safety data, which will certainly also back up the usage of those treatments. Here we had an inclusion of 11 phase 3 trials of the SELECT program and 5 observational studies. from routine clinical practice with about 5,000 patients and more than 17,000 patient years of exposure. The key takeaways of that study was that the serious treatment emergent adverse events rates and the adverse events leading to discontinuation were generally similar across the groups and disease states. The serious infection rates were generally similar, except the higher rates with upadacitinib versus methotrexate in rheumatoid arthritis and versus adalimumab in psoriatic arthritis, which was a finding mainly driven by COVID-19 or positivity or pneumonia thereof. Herpes zoster rates were associated with upadacitinib versus active comparators in rheumatoid arthritis and psoriatic arthritis. Malignancy, including non-melanoma skin cancer, was low and similar across the treatment groups. The rates of that were higher with UPA than with active comparators in those trials with RA and PSA. MACEs and VTEs were infrequent. They were broadly similar across treatment groups and disease states, and the clinical practice safety findings were generally consistent with all the data we know from the SELECT trial program. Of course, this observational data, or partly at least of it, is observational data, and we need to interpret them with caution because of potential confounding and bias. Another study was given by Graf and colleagues. It had to do with rosnilimab, a selective and potent depleter of pathogenic T cells. We know that the depletion of T cells is an important mechanism that we need to take into account. It is here the so-called Renoir study, a phase 2b trial in moderate to severe patients with rheumatoid arthritis. So rosnilimab is an investigational monoclonal antibody that selectively targets and depletes pathogenic T cell populations, including PD-1 high, TPH, TFH, and TF cells. So all of the subpopulations that we are looking into in this disease. Patients who were receiving background conventional synthetic DMARDs, they had lesser than or were allowed to have lesser than 3 prior treatment with biologics or targeted synthetic DMARDs, and altogether there were more than 400 patients who were randomized in that study. 40% or 41% had prior exposure to B or TS DMARDs. We had a 12-week placebo-controlled period included. All active rosnilimab treatment was up to week 28 and off-drug follow-up up to week 38 in order to allow for safety evaluation. What did we learn from that study? We did meet, or the study did meet, the primary endpoint, with all those groups showing significantly greater improvement in DAS28 at week 12 versus placebo. The ACR20 responses at week 12 were significantly higher with the active treatment with rosnilimab versus placebo. The responses were broadly consistent with both BOTS DMARDs naive and BTS DMARDs experienced patients. 69% of the patients treated with the active drug achieved a CDAI low disease activity at week 14 of the study and entered the all-active treatment period. The responses increased through week 28 among those patients who continue the treatment with active drug, including all the outcomes such as ACR50, 70, CDAI, LDA, HAQ-DI, and pain visual analog scale. The CDIA low disease activity was largely maintained during off-drug follow-up with up to 82% of the patients based on the dose that was applied, and we have a generally good toleration of the drug with rare or serious or opportunistic infections and no malignancies or deaths. So these findings do support the further evaluation of the pathogenic T cell depletion as a distinct therapeutic approach in rheumatoid arthritis. Another study had to do with comparison of 2 well-known drugs to us. It's the SUNSTAR study. It's the subcutaneous tocilizumab versus abatacept comparison in rheumatoid arthritis in patients with inadequate response to 1 or 2 prior DMARD, B or TS DMARDs. This means treatment. It's a head-to-head multi-center open-label randomized superiority trial. This is important because we, of course, do need to know exactly what we're doing with these different drugs, and we would like to see those head-to-head trials overall. Based on the comparison, we had the primary endpoint, which was the change from baseline in CDAI responses at week 26. And the key secondary endpoint was a composite response, including treatment response, CDAI less than 10, prednisone less than 10 milligram, and no intraarticular injections of glucocorticoids. So altogether, very much aligned to clinical practice. The key takeaways of that study was that tocilizumab did not demonstrate superiority over abatacept for the primary endpoint. The difference between the CDAI changes were not significant, 14.2 versus 11.8 for toci versus abatacept. In that regard, the composite response at week 26 significantly favored tocilizumab for 50% versus 35% in abatacept. This was statistically significant, but still as not assigned as a primary endpoint. The per protocol CDAI change at week 26 was also favoring tocilizumab, and the treatment persistence to week 52 was higher with tocilizumab as well, with 60%, 63% versus almost 47% for abatacept. So the findings suggest no clear superiority on the CDAI change of tocilizumab versus abatacept, but a better composite response and persistence for the IL-6 inhibition versus the abatacept treated arm. Then we have another trial which evaluated the efficacy and safety of zemprositinib. You may have heard of that drug in previous conferences. It was a randomized, double-blind, placebo-controlled phase 3 trial in patients with moderate to severe active rheumatoid arthritis who also had inadequate response to biologic DMARDs. It's the so-called COURAGE-RA trial. So we're speaking here about an oral selective JAK1 inhibitor, and you may have seen also in this or have heard in this Congress, we did have many new selective JAK1 inhibitors coming from China. Here we're speaking about one in rheumatoid arthritis. The other indications were also affected with other drugs. So the COURAGE trial evaluated zemprositinib 12 milligrams versus placebo, once daily versus placebo, in moderate to severe active rheumatoid arthritis with inadequate response to prior BDMARDs. 429 patients were included, and they were randomized one-on-one to either active drug or placebo. 22% of them had a prior JAK inhibitor exposure as well next to the other drugs, and most of them were active, obviously, and seropositive RA patients. The primary endpoint was ACR20 at week 24, and what we saw in that study was that indeed ACR20 and ACR50 already separated rapidly from placebo at week 2, and ACR70 separated already at week 4. There was a statistically significant difference to placebo with almost 80% for the active drug versus 40% in the placebo arm at week 24, which is a highly statistically significant difference. And the key secondary outcomes such as ACR50 and DAS28 CRP below 3.2 were also statistically significant. Overall, we had a very good toleration of the drug, and most treatment emergent adverse events were grade 1 or 2. This means really at a low level of severity. So altogether, indeed, both safety and efficacy and safety confirmed. There were no differences in the serious treatment emergent adverse events or any other serious events. We also had check of data for internal check for inconsistency, and altogether the discontinuations that were reported were similar between the drugs. Now, this was the part of rheumatoid arthritis. I would like to give over to Laura to tell us about psoriatic arthritis and continue with I think it's the first step together trial. Laura, is that correct?
Yeah, absolutely. So I think while we're focusing on psoriatic arthritis, actually, there was a huge amount of interest and discussion around obesity and treatment of obesity linked to that at EULAR. So I thought I'd kick off with the results of the Together PSA trial. So this is now actually published. This study looked at the use of ixekizumab with concomitant tirzepatide to try and control disease in patients with psoriatic arthritis who were overweight or obese. So we know that obesity is really key in psoriatic arthritis. It's increased with a higher chance of developing disease and poorer outcomes with most of our treatments. So the idea of this study was to evaluate adding tirzepatide to ixekizumab, obviously an effective therapy for PsA, versus ixekizumab alone in patients who had quite significantly active PsA but were also overweight or obese. Their baseline BMI was around 38, and they had very high disease activity at baseline, tender joint counts around 25, swollen joint counts around 10 to 11. And the primary endpoint was achievement of ACR 50 and greater than 10% weight reduction at week 36. So a bit longer trial than we would usually see in rheumatology, but typical for the weight loss trials. So it was obvious before we got the data that the combination of the two therapies was going to win on the primary outcome because ixekizumab doesn't help you lose weight. But when they compared ixekizumab and tirzepatide, just over 31% of patients achieved 10% weight loss plus ACR 50 in the dual treatment group, whereas less than 1% achieved that with ixekizumab alone. But I think the more interesting thing was to look at the ACR 50 responses on their own, so the chances of achieving good arthritis outcomes. That was statistically significant from week 4 through to week 36 in the trial. At week 4, the differences were around 11 versus 4%. By week 36, that was 33.5 versus just over 20%. So a significant increase in the chance of achieving ACR 50 with tirzepatide and with weight loss in this study. The improvements were seen across the different ACR components, so joint counts, patient-reported outcomes, global scores. The DAPSA improvement was also greater, as were DAPSA low disease activity and remission, and minimal disease activity, which increased at week 36 from 15.3% in the ICSI alone group versus 26.3% in the combination therapy group. The safety looked very in keeping with previous studies, so no increased risk of combining these two medications. The side effects were what you would expect for the two medications alone, which is reassuring. And I think gives us a real hint that controlling obesity is important and that we can actually now do it in a feasible and practical way with medical help. The second abstract to cover was a GRAPPA-OMRACT systematic review and network meta-analysis, which aimed to look at the different outcome measures that we use in clinical trials and how they perform. Obviously, we've shifted in recent years to using more PsA-specific outcome measures in psoriatic arthritis, but still a lot of the trials use the registration requirements like ACR 50, which is borrowed from rheumatoid arthritis. OMRACT has done obviously a lot of work on clinical trials in rheumatology, but previously has focused much more on single measures rather than composite outcome measures. And so this is part of the early work with OMRACT on composite measures and looking at the discriminant capacity of these different composite measures across all of the randomized controlled trials that were brought together that were placebo controlled, looking at biologics or targeted synthetic DMARDs. So there were 24 trials, around 12,000 participants. So this analysis looked at multiple composite measures. It showed that MDA had the greatest ability to distinguish active treatment from placebo with an odds ratio of just over 5. ACR 20 performed quite well with an odds ratio of 4. That's obviously the typical measure that was always used in the trials. In the more recent years, we've switched to ACR 50. PASDAS also performed well with an odds ratio of 3.7. DAPSA a little bit lower at 3.02, and CPDI the lowest at just below 2. So when they looked at the network meta-analysis, it was clear that ACR 20 performed better than DAPSA, MDA better than DAPSA, and PASDAS better than DAPSA. But the CPDI estimates were really limited because there wasn't much data on that. So I think this shows that we can think about moving endpoints of future PsA trials to think about endpoints that are more specific to PsA, cover multiple domains, which matches with what the patients want in terms of disease outcome, and that are thinking about higher bars of achievement, not just a 20% improvement, but actually getting somebody to minimal or low disease activity. The third abstract to cover was looking at the impact of disease-modifying therapies on metabolic liver disease in psoriatic disease. So obviously linked to discussions about obesity, liver disease is a big issue for our patients with psoriasis and psoriatic arthritis. They have an increased risk of MASLD, of metabolic-associated liver disease, and MASH, and it's thought to be linked in terms of inflammatory and metabolic pathways. So the idea of this study was to look at 6-monthly changes in psoriatic disease activity and liver health after a change in treatment had been undergone. And liver health was measured using standard liver function tests, the extended liver function or ELF score, and crucially, MRI imaging. This is a relatively small study of patients getting different drugs, but there were 36 patients, 26 with PsA and 10 with psoriasis. And even at baseline, 50% met imaging criteria for having metabolic-associated steatotic liver disease, and 25% met criteria for MASH, so showing how widespread this is. The liver disease was common and was often not detected by standard liver function tests, which I think we have seen before. Elevated ALT was only seen in around 30% of those with liver disease. Obviously, when we looked at these different medications, there was an improvement in disease activity. But in terms of liver disease, it seemed that the conventional DMARDs, which was mostly methotrexate, didn't really change the liver disease at all on imaging. TNF inhibitors produced the best improvement in joint disease, but no real change in liver disease, whereas IL-17A inhibitors included in this drug showed a signal for improved liver health, a reduction in liver fat, and a reduction in the CT1 score, which measures inflammation in the liver. So it's clear that imaging tests like this multiparametric MRI test are more sensitive for detecting liver disease compared to standard blood tests. And although this is a very small kind of exploratory study, it suggests potentially that blocking IL-17 could provide a benefit not only for the psoriasis and psoriatic arthritis, but also for the liver disease. The next abstract, also IL-17, but this time a head-to-head clinical trial comparing bimekizumab and risankizumab in patients with active psoriatic arthritis. This is the BE-BOLD study. This is a phase 3b study comparing bimekizumab and risankizumab using the standard doses in patients who had active psoriatic arthritis and were either biologic naive or had had a previous experience of one TNF inhibitor, so pretty early on in the disease course. The primary endpoint was ACR50 at week 16, and secondary outcomes included MDA, ACR50 plus PASI 100, as seen in previous head-to-head studies, as well as skin outcomes. So at week 16, bimekizumab was superior to risankizumab, looking at ACR50 response, just under 50%, 49.1% with bimekizumab, and 38.4% with risankizumab. So a strongly statistical different separation. And actually in the presentation at the meeting, although not in the abstract, we also saw data out to week 24, where that same difference was maintained in the longer follow-up of the study. This also was clearly different even as early as week 4, with better outcomes for bimekizumab. And there were numerically better outcomes for ACR50 plus PASI 100, PASI 100 and DAPSA remission. Interestingly, the MDA was a little bit higher in the bimekizumab group, but not statistically significant compared to risankizumab. Treatment emergent adverse events were broadly comparable, 57% with bimekizumab, 52% with risankizumab, which I think is really interesting because we think of IL-17s as being the safer of the biologics, but actually here IL-17s over 24 weeks look pretty similar, and the serious treatment emergent adverse events were low in both groups, and if anything, numerically slightly lower with bimekizumab. Obviously, you did get more candida infections with bimekizumab, but all of these were relatively mild or moderate and didn't lead to discontinuation of the drug. So I think these are really helpful studies. We love to have head-to-head studies when we're thinking about the number of different biologics we have available. And I think this supports the idea that you get a more rapid response and a higher response in terms of joint disease when thinking about IL-17AF treatment with bimekizumab versus IL-23.
Thank you, really. Thank you so much. Indeed, these were really very interesting presentations seen there. Okay, we will go on now, and we're very happy that Sofia Ramiro is with us, who will speak about the studies that have been selected for the axial spondyloarthritis part.
Thank you very much, Xenofon. And because of your introduction, we start with a study presented by you at EULAR, just because of that. So you have, of course, we have the exciting results of the Olinguito trial. So filgotinib phase 3 program in axSpA. Filgotinib is an oral JAK1 inhibitor, as we know, and in the Olinguito, filgotinib 200 milligram have been assessed once daily in patients with active axSpA throughout the whole spectrum in radiographic and non-radiographic axSpA. The primary endpoint was ASAS40 at 16 weeks, and it has been met in both populations. In radiographic axSpA, 40% have reached it compared to 21% in placebo, and in non-radiographic, 35% of patients with filgotinib have reached ASAS40 compared to 18% on placebo. ASAS40 responses occurred early from week 1 onwards and continued to improve up to week 52. And we have data until week 52. And the ASAS40 responses were also numerically higher with filgotinib in both BDMARD naive patients and also BDMARD insufficient response patients. Improvements were seen in disease activity, including objective signs of inflammation, so also CRP and MRI inflammation, function, overall functioning and health, and patient-reported outcomes. Improvements in outcomes were maintained or further improved actually until week 52. And in terms of safety, this was consistent with what we know from filgotinib, both from RA and from colitis. And there was in this trial no herpes zoster, no MACE, non-melanoma skin cancer or thrombotic event until week 16. So in conclusion, filgotinib is efficacious in the whole spectrum of axSpA with efficacy demonstrated already after 1 week of treatment. And we are now awaiting approval from EMA for the indication of axSpA, but expectedly we'll be able to expand the treatment armamentarium in axSpA with another efficacious drug, which is always welcome. And now we move to the second presentation. It's also a trial, and it's a trial that compared IL-17A inhibitor with a TNF inhibitor after a failure of a first TNF inhibitor in axSpA. So these are the results from the axSpA study that were presented by Hubert Marotte. And actually, the background is that in our daily clinical practice, after the failure of a first TNF inhibitor, we actually do not have solid data to guide us whether to start another TNF inhibitor, and so to cycle TNF inhibitor, or to switch to another mode of action. So here, patients with active axSpA were randomized either to switch to an IL-17A inhibitor or to cycle to a second TNF inhibitor. This is a phase 4 randomized, multicenter and open label superiority trial. The primary endpoint was ASAS40 at week 24. And what we saw is that switching to an IL-17A inhibitor was not superior to cycling to a second TNF inhibitor. At week 24, ASAS40 response was similar in both treatment arms, with IL-17A 15.2% and with TNF inhibitor 14.5%, so actually the same. No significant between group differences were seen for secondary endpoints. ASAS declined similarly in both treatment arms throughout follow-up, and treatment maintenance at week 54 was numerically higher with IL-17A inhibitors 63 versus 55%, without any new safety signals identified, as we actually expected. So the findings actually support individualized treatment sequencing rather than knowing or assuming a superior efficacy from one or other mechanism of action after failure of a TNF inhibitor. This was a very important trial addressing a question we are faced with in our daily clinical practice. So good to have evidence that there is now for it. Then we move to another trial, actually, from the group from Ghent, presented by Philippe Caron on the immediate TNF blockade that outperformed step-up CS-DMARDs in early peripheral spondyloarthritis. So this is the Spartacus trial, 24-week trial. And this trial then tested whether early biologic introduction could improve outcomes in newly diagnosed patients with peripheral SPA. Actually, nowadays, we usually start with conventional synthetic DMARDs, and then eventually in those that don't respond, escalate to biologics. And here they compared both treatment strategies. Patients had to have active peripheral SPA of less than 1 year of symptom duration. And they compared first-line golimumab as the early TNF inhibitor blockade compared to step-up conventional synthetic DMARDs approaching, starting with methotrexate. Primary endpoint was the complete absence of arthritis, dactylitis, or enthesitis at week 24. And in this trial, we have seen that the immediate blockade with TNF inhibitor was superior to CS-DMARD step-up for 24 weeks, in which clinical remission was achieved with TNF inhibitor with 60% compared to 33% for the CS-DMARD step-up, with an absolute difference of 28%, which is statistically significant and clinically relevant. Sustained clinical remission was obtained, and this was measured or reported now until week 24, was also higher with TNFI induction, 42% versus 18% with the CS-DMARD step-up. And TNF inhibition induction improved other key clinical measures at week 24, including tender joint count, swollen joint count, patient global assessment, and pain. There was only one serious adverse event that occurred in the TNF inhibitor induction arm. Patient had flu-like symptoms requiring hospitalization, but for the rest, no important signals on safety coming out of this trial. So the findings of this trial support potentially an early therapeutic window for disease interception in peripheral SPA. And it will actually be interesting to see longer-term follow-up of this early and more aggressive approach. And it can be very well that in the future we change the paradigm and start treating patients more aggressively with the aim of then being able to taper treatment sooner. So I think more to come on this. Now switching to another trial, the FASTLANE, presented by Valeria Rios Rodriguez on tofacitinib in early active axial SPA. It was a trial in early active axial SPA defined as a back pain duration of up to 2 years of symptom duration. Patients were naive to advanced treatment and had objective signs of inflammation, either with MRI inflammation or CRP or both. Patients were randomized into tofacitinib 5 mg BID together with naproxen 500 mg BID or placebo together with naproxen, the same dosages. And the primary endpoint was ASDAS inactive disease at week 16, so a quite stringent endpoint that we are not used to seeing as a primary endpoint. And in this trial, it was found that tofacitinib was superior to placebo for ASDAS inactive disease at week 16, with the achievement rate of 26% compared to 7% in placebo, statistically significant. And treatment escalation to open label tofacitinib due to non-response at week 4 was more frequent with placebo as expected, 57% with placebo compared to 34% in the tofacitinib arm. And there was an improvement, numerically improvement in MRI scores on inflammation favoring tofacitinib. And there was also an improvement in secondary clinical endpoints as ASDAS low disease activity, clinically important and major improvement, ASDAS 20 and 40, back pain, among others. Safety was consistent with the tofacitinib profile that we know of. There were no death or adverse events of special interest. So in conclusion, and as expected, tofacitinib is efficacious in early axSpA, but here we have a very stringent endpoint, ASDAS inactive disease. And now that we have a definition of early axSpA, it's good to see trials designed in this specific population. Now moving to the SELECT axis-2 trial, and actually a follow-up phase of that trial in which Atul Deodar presented withdrawal from upadacitinib in patients with the axSpA. So patients that were in the SELECT axis trial on upadacitinib and that were in remission as measured with ASDAS inactive disease at week 104, so 2 years, they entered an open label withdrawal. And when they had a flare, this triggered retreatment with upadacitinib 15 milligram daily for 24 weeks. And the main findings are actually that among the above more than 700 patients included in the SELECT-2 axis, 194 achieved ASDAS inactive disease at week 104, so that's 1/5 of the patients, and they entered withdrawal. After 48 weeks of withdrawal, 22% maintained their state of ASDAS inactive disease, which means that the others flared, and the median time to flare overall was 3.1 months. In radiographic axSpA in patients that were biological DMARD insufficient responder, the time was a little bit shorter, 2.8 months, and in non-radiographic axSpA, it was 5 months. After retreatment, so patients that flare were retreated with upadacitinib, and most patients recaptured disease control. So an ASDAS, at least LDA, so ASDAS below 2.1, was recaptured in 72% of the patients by week 2, and in 89% of the patients by week 24, and also a high percentage of patients recaptured inactive disease. Upadacitinib was generally well tolerated when patients were retreated with no new safety concerns identified. And I think that this trial addresses an unmet need that we had in axSpA. We have withdrawal studies with TNF inhibitor and with IL-17 inhibitors, but we did not have them yet with JAK inhibitors. Not surprisingly, not so many patients keep disease control if treatment is abruptly withdrawn. But the next step will probably be to have a tapering study with JAK inhibitors as we would approach a patient with in ASDAS inactive disease, so in remission in our daily clinical practice. And now moving to the last poster that I would like to highlight, presented by Walter Maksimovic on the impact of bimekizumab on MRI inflammatory and structural lesions in patients with non-radiographic axSpA, data from the B-Mobile 1 trial. And what we have seen is that bimekizumab produced sustained reductions in inflammation on the MRI and over 2 years. And also there was a large number of patients achieving or maintaining remission on MRI. So half of the patients, 53% at week 52 and 51% at week 104. And structural changes that were developing throughout time suggested potential tissue repair in the sense that the changes that there were seen with erosions, backfill, and fat were maintained throughout time without more changes under treatment with bimekizumab. And there was no ankylosis that was observed. So this means that in addition to having demonstrated efficacy on disease activity and other relevant disease domains, we now see that bimekizumab can lead to an inflammation on MRI controls and that the development of structural lesions is low. And I think this was the summary that I would like to bring to you on axSpA. Thank you very much. Xenofon, over to you again.
Thanks so much, Sofia. Well, this is what we have for today. I hope you've enjoyed this EULAR 2026 review podcast. Don't forget to visit the IMED forum at imedforum.com. There you will find a wide range of educational resources covering rheumatology, dermatology, and gastroenterology, including detailed slide decks highlighting the most important research from major congresses, expert-led podcasts, webinars, and practical clinical insights from international specialists. Thank you for listening, and as always, best of luck in your clinical practice.